Question 1. A 68-year-old male is admitted with acute exacerbation of chronic obstructive pulmonary disease, COPD. He also has documented type 2 diabetes mellitus with diabetic neuropathy and chronic systolic heart failure. What is the correct principal diagnosis for this admission? A. J44.1, chronic obstructive pulmonary disease with acute exacerbation. B. I50.22, chronic systolic, congestive, heart failure, unspecified. C. E11.40, type 2 diabetes mellitus with diabetic neuropathy, unspecified. D. J44.9, chronic obstructive pulmonary disease, unspecified. Answer: A. J44.1, chronic obstructive pulmonary disease with acute exacerbation. This question tests understanding of principal diagnosis selection in an inpatient setting. The key phrase "admitted with acute exacerbation of chronic obstructive pulmonary disease" indicates that the COPD exacerbation is the condition chiefly responsible for the inpatient admission. While the patient has other chronic conditions, the principal diagnosis is the condition established after study to be the reason for the admission, not necessarily the most complex or long-standing issue. For example, if a patient is admitted for a hip fracture but also has controlled hypertension, the fracture is the principal diagnosis. Always select the condition that directly led to the patient's hospitalization. Question 2. A patient undergoes an arthroscopy of the right knee with meniscectomy, removal of meniscus. What CPT code category should the coder focus on? A. Spine procedures. B. Musculoskeletal system. C. Integumentary system. D. Digestive system. Answer: B. Musculoskeletal system. This question evaluates basic knowledge of CPT code organization. The keywords arthroscopy, knee, and meniscectomy all refer to procedures performed on a joint and bone, which are components of the musculoskeletal system. CPT codes are grouped by body system or type of service, making it crucial to identify the correct section for efficient code lookup. For instance, if the procedure involved removing a skin lesion, you would look in the integumentary section, but for a bone or joint procedure, the musculoskeletal section is the correct starting point. Knowing the CPT structure helps you navigate the manual quickly and accurately. Question 3. According to AHA coding clinic guidance, which of the following is true regarding the coding of present on admission, POA, indicators? A. POA indicators are only required for principal diagnoses. B. Conditions that develop during an outpatient observation stay should always be coded as Y, yes, for POA. C. Conditions documented as history of should be coded as N, no, for POA. D. For conditions integral to a procedure, e.g., postoperative bleeding as a complication of surgery, the POA indicator reflects whether the bleeding was present at the time of admission. Answer: D. For conditions integral to a procedure, e.g., postoperative bleeding as a complication of surgery, the POA indicator reflects whether the bleeding was present at the time of admission. This question assesses knowledge of present on admission, POA, indicator guidelines, which can be complex. The guideline states that for conditions that are complications of care, like postoperative bleeding, the POA indicator should reflect whether the complication itself was present at the time of the inpatient admission, not just the underlying condition. For example, if a patient developed a surgical site infection 3 days after admission, it would be N, no, for POA, even if the surgery was performed after admission. Always focus on when the specific condition or complication first manifested in relation to the inpatient admission. Question 4. A patient is seen in the outpatient clinic for routine postoperative follow-up 30 days after a laparoscopic appendectomy. The patient's only complaint is mild incision discomfort, which is expected. The surgeon performs a brief exam, states the patient is healing well, and discharges them from postoperative care. What CPT code, if any, should be reported for this visit? A. 99,213. B. 99,024. C. 44,970. D. No separate code is reported, as it's included in the global surgical package. Answer: D. No separate code is reported, as it's included in the global surgical package. This question tests understanding of the CPT global surgical package. The phrase routine postoperative follow-up 30 days after indicates the visit falls within the typical global period, which is 90 days for major surgeries like appendectomy. Routine postoperative care, including expected follow-up visits for incision discomfort and healing, is bundled into the original surgical code and is not separately billable. For example, if the patient developed a new, unrelated condition during the post-op period, that visit might be billable, but routine checks are not. Remember, 99024 is for tracking purposes and is not a billable code to the payer. Question 5. A patient is admitted for elective total hip arthroplasty due to severe osteoarthritis. During the preoperative workup, the patient's chronic atrial fibrillation, which was previously stable, becomes unstable, requiring initiation of new medication and closer monitoring. What is the correct sequencing of diagnoses? A. I-48.91, unspecified atrial fibrillation, M16.9, unspecified osteoarthritis, hip. B. M16.9, unspecified osteoarthritis, hip, I-48.91, unspecified atrial fibrillation. C. I-48.91, unspecified atrial fibrillation, M16.9, unspecified osteoarthritis, hip, Z53.01, anesthesia risk procedure not carried out due to contraindication. D. M16.9, unspecified osteoarthritis, hip, Z53.01, anesthesia risk procedure not carried out due to contraindication. Answer: B. M16.9, unspecified osteoarthritis, hip, I-48.91, unspecified atrial fibrillation. This question focuses on principal diagnosis sequencing when a patient is admitted for a planned procedure but develops a complication or unstable condition preoperatively. The principal diagnosis should still be the condition for which the patient was primarily admitted, which is the severe osteoarthritis requiring hip arthroplasty. The atrial fibrillation, even if it became unstable, is a secondary diagnosis because it arose during the admission for the planned surgery and did not change the primary reason for admission itself. Think of it this way: the patient was admitted for the hip replacement, and the atrial fibrillation became a comorbidity that complicated the stay. Question 6. A patient is diagnosed with severe sepsis due to urosepsis, with septic shock and acute renal failure. What is the correct ICD-10-CM coding and sequencing for this scenario? A. R65.20, severe sepsis without septic shock, N39.0, urinary tract infection, site unspecified, R65.21, severe sepsis with septic shock, N17.9, acute kidney failure, unspecified. B. A41.9, sepsis, unspecified organism, R65.21, severe sepsis with septic shock, N39.0, urinary tract infection, site unspecified, N17.9, acute kidney failure, unspecified. C. R65.21, severe sepsis with septic shock, N17.9, acute kidney failure, unspecified, N39.0, urinary tract infection, site unspecified. D. R65.21, severe sepsis with septic shock, N39.0, urinary tract infection, site unspecified, N17.9, acute kidney failure, unspecified. Answer: C. R65.21, severe sepsis with septic shock, N17.9, acute kidney failure, unspecified, N39.0, urinary tract infection, site unspecified. This question tests complex sequencing rules for sepsis, severe sepsis, septic shock, and associated organ dysfunction. When a patient has severe sepsis with septic shock, the code for severe sepsis with septic shock, R65.21, must be sequenced first. Following this, codes for all associated organ dysfunctions due to the sepsis are sequenced. Finally, the code for the underlying infection, urosepsis, which codes to urinary tract infection N39.0, is sequenced last. It's crucial to remember this specific hierarchy, R65.21 organ dysfunctions underlying infection. Question 7. A 45-year-old patient undergoes an excisional biopsy of a suspicious lesion on their back, measuring 1.5 centimeters. Pathology later confirms it is a benign nevus. The closure was a simple repair. What CPT codes should be reported? A. 11402, 12002. B. 11402. C. 11602, 12002. D. 11602. Answer: B. 11402. This question tests the coding of benign excisions and repair. The keyword excisional biopsy implies complete removal, and benign nevus confirms it's a benign lesion. CPT codes for excision of benign lesions 11400, 11446 include simple closure. Since the closure was explicitly documented as simple repair, it is bundled into the excision code and should not be reported separately. For example, if it were an intermediate or complex repair, then a separate repair code would be reported in addition to the excision. Always check if the repair type is explicitly stated and if it warrants separate coding according to CPT guidelines. Question 8. A patient presents for a scheduled colonoscopy. During the procedure, the physician identifies and removes a single polyp from the sigmoid colon using a hot biopsy forceps. What CPT code should be reported? A. 45,380. B. 45,385. C. 45,378. D. 45,384. Answer: A. 45380. This question assesses proper CPT coding for colonoscopy with polypectomy based on the removal method. The keyword hot biopsy forceps indicates the specific technique used for polyp removal. Code 45380 is specifically for a colonoscopy with removal of a lesion by hot biopsy forceps or bipolar cautery. Code 45385 is for polypectomy by snare technique, which is a different method. Always pay close attention to the method of lesion removal during endoscopic procedures, as this often dictates the correct CPT code. Question 9. In the healthcare revenue cycle, what is the primary purpose of Charge Description Master (CDM) reconciliation? A. To identify discrepancies between charges posted to patient accounts and services documented in the medical record. B. To ensure all claims are submitted to payers within timely filing limits. C. To update patient demographic information prior to billing. D. To resolve claim denials from insurance companies. Answer: A. To identify discrepancies between charges posted to patient accounts and services documented in the medical record. This question tests understanding of the Charge Description Master (CDM) and its role in revenue cycle management. CDM reconciliation is a process designed to regularly review and compare the services that were actually provided and documented in the patient's chart against the charges that were generated and placed on the patient's bill. This helps ensure accuracy, compliance, and proper reimbursement by catching errors like missing charges or incorrect charges. For instance, if a specific supply was used but not charged, CDM reconciliation helps identify that gap. The goal is to maintain the integrity of the billing process. Question 10. A patient is seen in the emergency department, ED, for severe abdominal pain. The physician performs a comprehensive history, comprehensive exam, and medical decision-making, MDM, of high complexity. What is the appropriate E/M code for this ED visit? A. 99,283. B. 99,284. C. 99,285. D. The code cannot be determined without knowing the time spent. Answer: C. 99285. This question evaluates the coding of emergency department, ED, visits. ED visits, 99,281 to 99,285, are traditionally coded based on three key components: history, examination, and medical decision-making, MDM. The documentation clearly states comprehensive history, comprehensive exam, and medical decision-making of high complexity, which are the highest levels for each component. Therefore, 99285 is the correct code, as it represents the highest level of ED service. Unlike some other E/M categories, time is not a controlling factor for ED E/M code selection. Question 11. Which of the following best describes the purpose of the National Correct Coding Initiative, NCCI, edits? A. To ensure appropriate reimbursement for services by preventing unbundling of procedures. B. To establish the official coding guidelines for ICD-10-CM diagnoses. C. To define medical necessity for all CPT and HCPCS codes. D. To dictate the correct sequencing of diagnoses on claims. Answer: A. To ensure appropriate reimbursement for services by preventing unbundling of procedures. This question tests understanding of the National Correct Coding Initiative, NCCI, edits, a crucial compliance tool. The primary purpose of NCCI edits, developed by CMS, is to prevent improper coding leading to inappropriate payment. They achieve this by identifying procedures that are typically performed together and should not be billed separately, unbundling, or those that are mutually exclusive. For example, an NCCI edit might prevent separate billing for a surgical procedure and an incision and drainage that is integral to that surgery. These edits are essential for promoting accurate and compliant coding practices. Question 12. A patient undergoes an MRI of the brain without contrast. The radiologist dictates the findings, but a separate report is not provided. Instead, the findings are documented within the physician's office notes. What CPT code and modifier, if any, should be reported by the facility for the technical component of the MRI? A. 70551 TC. B. 70,551. C. 70,551 to 26. D. No code should be reported by the facility. Answer: A. 70551 TC. This question assesses understanding of the technical and professional components of diagnostic procedures. The keyword facility indicates billing for the technical component, which includes the equipment, supplies, and technologist services. Modifier TC, technical component, is appended to codes for diagnostic tests to indicate only the technical portion was provided. The radiologist's interpretation, even if documented in the office notes, represents the professional component, minus 26 modifier, which would be billed by the physician group. For example, when a hospital performs an MRI, they bill the technical component, and the interpreting radiologist bills the professional component. Question 13. A patient is admitted for a severe acute exacerbation of asthma. While hospitalized, the patient develops hypoxemia requiring continuous oxygen therapy and is monitored closely. The patient has a history of mild intermittent asthma. What is the correct principal diagnosis? A. J45.909, unspecified asthma, uncomplicated. B. J45.901, unspecified asthma with acute exacerbation. C. J45.21, mild intermittent asthma with acute exacerbation. D. R09.02, hypoxemia. Answer B. J45.901, unspecified asthma with acute exacerbation. This question tests the coding of asthma exacerbations and the principal diagnosis concept. The key phrase, severe acute exacerbation of asthma, points to the primary reason for admission. According to ICD-10-CM guidelines, when asthma is described as acute exacerbation, it implies a worsening of the patient's baseline asthma. Even though the patient has a history of mild intermittent asthma, the exacerbation is the more specific and principal reason for the encounter, so a code for unspecified asthma with acute exacerbation is appropriate when the severity is not specified further for the exacerbation itself. The hypoxemia is a symptom or manifestation of the asthma exacerbation, not the principal diagnosis. Question 14. Which of the following is true regarding HCPCS Level II codes? A. They are primarily used to report physician services and procedures. B. They are standardized codes for supplies, durable medical equipment, and non-physician services. C. They are maintained by the World Health Organization, WHO. D. They are mandatory for all inpatient hospital billing in the United States. Answer B. They are standardized codes for supplies, durable medical equipment, and non-physician services. This question assesses knowledge of HCPCS Level II codes, a distinct coding system. HCPCS Level II codes are created and maintained by the Centers for Medicare and Medicaid Services, CMS, and are used to report medical supplies, durable medical equipment, DME, orthotics, prosthetics, and certain services not covered by CPT codes. For example, a wheelchair or certain types of injectable drugs administered in an outpatient setting would be billed with a HCPCS Level II code. These codes complement CPT codes, which primarily describe physician and other health professional services. Question 15. A patient presents with a laceration on the left arm measuring 8.0 centimeters. The wound required extensive debridement of contaminated tissue and a layered closure. What is the correct CPT coding for this scenario? A. 12,034. B. 13,121. C. 13121, 11042. D. 11042, 13121. Answer B. 13121. This question tests the coding of complex wound repair, specifically involving debridement. The keywords laceration, 8.0 centimeters, left arm, extensive debridement of contaminated tissue, and layered closure indicate a complex repair. CPT guidelines state that debridement is included in the repair codes when it's necessary to prepare the wound for closure and does not require a separate code. Code 13121 is for complex repair of wounds to the extremities, like the arm, measuring 7.6 centimeters to 12.5 centimeters. If the debridement was truly extensive and not integral to the repair, a separate debridement code might be warranted, but extensive debridement of contaminated tissue implies it was part of preparing the wound for a complex repair, making it bundled. Question 16. A hospital performs a financial audit of its coding practices. The audit reveals a consistent pattern of coders assigning higher-paying CPT codes than the medical record documentation supports. This practice is best described as A. Unbundling. B. Upcoding. C. Cloning. D. Medically unnecessary services. Answer B. Upcoding. This question defines a common compliance issue in medical coding. The phrase assigning higher-paying CPT codes than the medical record documentation supports is the definition of upcoding. This is an unethical and illegal practice that results in inflated reimbursement for services that were not truly rendered or documented at the billed level. For example, billing an extensive office visit, 99215, when the documentation only supports a moderate one, 99213, would be upcoding. Understanding and avoiding upcoding is critical for ethical and compliant coding. Question 17. A patient with end-stage renal disease, ESRD, secondary to type 1 diabetes is admitted for peritoneal dialysis. The patient also has diabetic retinopathy and diabetic neuropathy. What is the correct principal diagnosis? A. E10.65, type 1 diabetes mellitus with hyperglycemia. B. N18.6, end-stage renal disease. C. Z99.2, dependence on renal dialysis. D. E10.21, type 1 diabetes mellitus with diabetic nephropathy, end-stage renal disease. Answer: D. E10.21, type 1 diabetes mellitus with diabetic nephropathy, end-stage renal disease. This question tests the specific coding guideline for diabetes with complications, especially ESRD. When ESRD is due to diabetes, the diabetes code is sequenced first, with an additional code for the specific type of diabetic renal complication that led to ESRD. The phrase ESRD secondary to type 1 diabetes indicates that the diabetes is the underlying cause. Therefore, the combination code for type 1 diabetes with diabetic nephropathy, end-stage renal disease, E10.21, is the most appropriate principal diagnosis, capturing both conditions in one code. Dependence on dialysis, Z99.2, is a secondary code. Question 18. A physician dictates an office note stating, patient presents for follow-up of hypertension. BP 130/80. Stable. Continue current medication. Which ICD-10-CM code should be reported for this visit? A. I-10, essential, primary, hypertension. B. Z00.00, encounter for general adult medical examination without abnormal findings. C. Z01.810, encounter for cardiovascular examination, routine. D. R03.0, elevated blood pressure reading, without diagnosis of hypertension. Answer: A. I-10, essential, primary, hypertension. This question highlights the difference between a screening/routine exam and a follow-up for a known chronic condition. The keywords follow-up of hypertension indicate that the patient has a diagnosed condition that is being managed, not just a routine checkup or a finding of elevated blood pressure without a diagnosis. Even if the blood pressure is stable, the reason for the visit is the management of the pre-existing hypertension. Therefore, I-10, essential, primary, hypertension, is the correct code. Question 19. A patient is admitted to an inpatient psychiatric unit due to an acute psychotic episode triggered by an opioid use disorder, severe, with intoxication. What is the correct sequencing of diagnoses? A. F11.229, opioid use disorder, severe, with intoxication, uncomplicated, F23, unspecified psychotic disorder. B. F23, unspecified psychotic disorder, F11.229, opioid use disorder, severe, with intoxication, uncomplicated. C. F11.129, opioid abuse with intoxication, uncomplicated, F23, unspecified psychotic disorder. D. F20.9, schizophrenia, unspecified, F11.229, opioid use disorder, severe, with intoxication, uncomplicated. Answer: B. F23, unspecified psychotic disorder, F11.229, opioid use disorder, severe, with intoxication, uncomplicated. This question tests the sequencing of mental and behavioral disorders due to psychoactive substance use. According to ICD-10-CM guidelines for substance-related disorders with associated mental conditions, if the mental condition, e.g., acute psychotic episode, is the reason for the admission, it is sequenced as the principal diagnosis. The underlying substance use disorder, opioid use disorder, is then sequenced as a secondary diagnosis. Therefore, the psychotic disorder, F23, is the principal diagnosis, followed by the opioid use disorder, F11.229. Question 20. A coder discovers that a physician consistently documents mild dehydration for patients, but the signs and symptoms, e.g., elevated BUN, dry mucous membranes, decreased urine output, actually point to moderate dehydration. The coder queries the physician, who agrees to clarify the documentation. This process is known as A. Downcoding prevention, B. Clinical documentation improvement, CDI, C. Charge capture optimization, D. Compliance monitoring. Answer: B. Clinical documentation improvement, CDI. This question describes a core function of clinical documentation improvement, CDI. CDI is a process where a specialist, often a nurse or coder, reviews medical record documentation for clarity, completeness, and accuracy, and then queries the healthcare provider to obtain the necessary clarification. This ensures that the documented conditions and treatments accurately reflect the patient's severity of illness and resources consumed, which then supports accurate coding and billing. For example, clarifying mild to moderate dehydration based on clinical indicators ensures the code reflects the patient's true condition. Question 21. A patient presents to the hospital for an urgent, unscheduled percutaneous transluminal coronary angioplasty, PTCA, of a native coronary artery. What modifier should be appended to the CPT code for the PTCA to indicate the urgent nature of the service in a hospital setting? A. -59. B. -22. C. No modifier is needed for urgent services. D. ER. Answer: C. No modifier is needed for urgent services. This question tests the appropriate use of modifiers in a hospital setting, specifically for urgent procedures. CPT modifiers like -59, distinct procedural service, or -22, increased procedural services, indicate unusual circumstances or separate services. However, there is no specific CPT modifier to indicate an urgent or unscheduled procedure itself when performed in a hospital setting. The urgency is often reflected in the type of CPT code, e.g., for an emergency department visit, or through the patient's admission status, e.g., emergent inpatient admission, but not typically by a CPT modifier on the procedure code itself. Question 22. A patient is undergoing chemotherapy for metastatic breast cancer to the bone. During a visit, the patient develops severe nausea and vomiting due to the chemotherapy. What is the correct sequencing of diagnoses for this encounter? A. C50.919, malignant neoplasm of unspecified site of breast, Z51.11, encounter for antineoplastic chemotherapy, R11.2, nausea with vomiting, unspecified. B. R11.2, nausea with vomiting, unspecified, C79.51, secondary malignant neoplasm of bone, Z51.11, encounter for antineoplastic chemotherapy. C. Z51.11, encounter for antineoplastic chemotherapy, R11.2, nausea with vomiting, unspecified, C50.919, malignant neoplasm of unspecified site of breast, C79.51, secondary malignant neoplasm of bone. D. R11.2, nausea with vomiting, unspecified, C50.919, malignant neoplasm of unspecified site of breast, C79.51, secondary malignant neoplasm of bone, Z51.11, encounter for antineoplastic chemotherapy. Answer, D. R11.2, nausea with vomiting, unspecified, C50.919, malignant neoplasm of unspecified site of breast, C79.51, secondary malignant neoplasm of bone, Z51.11, encounter for antineoplastic chemotherapy. This question tests the sequencing of chemotherapy complications. When the patient is admitted or seen for a complication of chemotherapy, like severe nausea and vomiting, the complication is sequenced as the principal or primary diagnosis. The malignancy, primary and any metastatic sites, is then sequenced, followed by the encounter for chemotherapy code, Z51.11. This is because the nausea and vomiting is the reason for the encounter, not the chemotherapy itself. Question 23. A patient is seen by a cardiologist for evaluation of chest pain. The physician performs an extensive review of systems, complete past, family, and social history, and a comprehensive physical exam. Medical decision-making is of moderate complexity. This patient is a new patient to the practice. What is the correct E/M code? A. 99203. B. 99204. C. 99214. D. 99205. Answer, B. 99204. This question evaluates E/M coding for new patients. For new patient E/M codes, 99202 to 99205, 2 out of 3 key components must meet or exceed the level of service. The documentation states extensive review of systems and complete past, family, and social history, which together meet the comprehensive history requirement. It also states comprehensive physical exam and medical decision-making of moderate complexity. Therefore, the history, exam, and MDM all meet or exceed the requirements for a 99204, comprehensive history, comprehensive exam, moderate MDM. Question 24. A coder is reviewing documentation for a patient discharged from the hospital. The physician notes that the patient had a urinary tract infection, UTI, on admission, but it resolved with antibiotics and was not significant for the length of stay. How should the UTI be coded? A. Code the UTI as a secondary diagnosis, with a POA indicator of Y. B. Code the UTI as a secondary diagnosis, with a POA indicator of N. C. Do not code the UTI, as it was resolved and not significant. D. Query the physician for clarification on its significance. Answer, A. Code the UTI as a secondary diagnosis, with a POA indicator of Y. This question addresses coding conditions that resolve during the hospital stay. Even if a condition resolves and is documented as not significant in terms of prolonging the stay, if it was present on admission and received any treatment or monitoring during the stay, it should still be coded. The key is that it was present on admission, Y4 POA, and managed. For example, a minor condition that was managed and resolved, like a mild rash, would still be coded if documented and treated, even if it didn't impact the overall hospital course. The not significant note does not eliminate the need to code a documented and treated condition. Question 25. Which coding convention in ICD-10-CM indicates that two conditions are mutually exclusive and should not be reported together? A. Code first note. B. Excludes one note. C. Excludes two note. D. Use additional code note. Answer, B. Excludes one note. This question tests understanding of critical ICD-10-CM coding conventions. An excludes one note indicates that the code excluded should never be used with the code above the note because the two conditions are mutually exclusive, meaning they cannot occur together. For example, if a code for congenital pneumonia has an excludes one note for pneumonia, unspecified, it means a patient cannot have both. The specific congenital type would be coded. In contrast, excludes 2 indicates that the condition is not included but a patient could have both conditions at the same time. Question 26. A 70-year-old male is admitted for pneumonia. He also has documented severe protein-calorie malnutrition and stage 2 pressure ulcer on his sacrum. What is the correct sequencing of these conditions for coding? A. J18.9, pneumonia, unspecified organism, L89.152, pressure ulcer of sacral region, stage 2, E43, unspecified severe protein-calorie malnutrition. B. E43, unspecified severe protein-calorie malnutrition, J18.9, pneumonia, unspecified organism, L89.152, pressure ulcer of sacral region, stage 2. C. L89.152, pressure ulcer of sacral region, stage 2, E43, unspecified severe protein-calorie malnutrition, J18.9, pneumonia, unspecified organism. D. J18.9, pneumonia, unspecified organism, E43, unspecified severe protein-calorie malnutrition, L89.152, pressure ulcer of sacral region, stage 2. Answer: D. J18.9, pneumonia, unspecified organism, E43, unspecified severe protein-calorie malnutrition, L89.152, pressure ulcer of sacral region, stage 2. This question tests principal diagnosis and secondary diagnosis sequencing. The pneumonia is the reason for the admission, making it the principal diagnosis. Both severe protein-calorie malnutrition and the stage 2 pressure ulcer are coexisting conditions that affect the patient's care and potentially the length of stay, thus they are secondary diagnoses. There is no specific guideline dictating the order of secondary conditions unless one directly complicates another or there's a code first note. However, conditions that significantly impact patient care, like severe malnutrition, often follow the principal diagnosis, then other conditions like pressure ulcers. Question 27. When coding for a patient presenting with symptoms of fever, cough, and shortness of breath, and the physician documents suspected COVID-19, what is the appropriate coding approach in an outpatient setting if testing results are pending? A. Code only the symptoms, e.g., R05 for cough, R06.02 for shortness of breath, R50.9 for fever. B. Code B97.29, other coronavirus as cause of diseases classified elsewhere, as the primary diagnosis. C. Code Z20.822, contact with and, suspected, exposure to COVID-19, as the primary diagnosis. D. Query the physician for a definitive diagnosis before coding. Answer: A. Code only the symptoms, e.g., R05 for cough, R06.02 for shortness of breath, R50.9 for fever. This question tests the coding of suspected conditions and the specific guidelines for COVID-19 in outpatient settings when a definitive diagnosis is not yet confirmed. In an outpatient setting, if COVID-19 is suspected but not confirmed by a positive test, or if the test results are pending, the correct guideline is to code the signs and symptoms the patient is presenting with. It is inappropriate to code a confirmed diagnosis or suspected exposure when the patient is symptomatic and being evaluated for the illness itself. Only once a definitive diagnosis is established can a specific COVID-19 code be assigned. Question 28. A patient undergoes an initial application of a short leg cast due to a closed fracture of the tibia. What type of CPT code is used for the cast application? A. A surgical code. B. An E/M code. C. A casting/strapping code. D. A durable medical equipment code. Answer: C. A. Casting/strapping code. This question tests knowledge of specific CPT code sections for procedures. The keywords initial application and short leg cast directly point to codes found in the application of casts and strapping section of the CPT manual, codes 29,000 to 29,799. These codes are distinct from surgical codes, which describe the fracture repair itself, or E/M codes, for the visit to assess the injury. For example, if the physician performed an open reduction of the fracture and then applied the cast application would typically be bundled into the surgical code. However, for an initial application without surgical intervention, a casting code is appropriate. Question 29. The purpose of a hospital's compliance plan is primarily to A. Maximize reimbursement from all payers. B. Ensure all employees receive annual HIPAA training. C. Prevent and detect fraud, waste, and abuse in billing and coding. D. Dictate clinical pathways for patient care. Answer: C. Prevent and detect fraud, waste, and abuse in billing and coding. This question focuses on the core purpose of a healthcare organization's compliance plan. The primary goal of a robust compliance plan, as recommended by the Office of Inspector General, OIG, is to establish a system that prevents, detects, and corrects instances of fraud, waste, and abuse, particularly in billing and coding practices. While it may include HIPAA training and indirectly impact reimbursement, its main objective is ethical and legal adherence, safeguarding the organization from penalties and promoting integrity. For example, a compliance plan outlines policies for internal audits and employee training to ensure accurate coding. Question 30. A patient receives a COVID-19 vaccine, second dose, using a Moderna product. Which of the following best describes the correct coding for this administration in an outpatient setting? A. 90471 M00.2. B. 90472 Z23. C. 0072A 90472. D. 0072A. Answer: D. 0072A. This question tests current coding for COVID-19 vaccine administration, which uses specific CPT codes and product-specific administration codes. The keywords COVID-19 vaccine, second dose, and Moderna product are crucial. For COVID-19 vaccines, CPT introduced specific administration codes, e.g., 0001A0094A, which are product and dose specific, and these codes include the administration component. Therefore, only the code 0072A, which specifies the second dose of the Moderna vaccine, is needed. Traditional vaccine administration codes like 90,471 or 90,472 are not used for COVID-19 vaccines, and Z23, encounter for immunization, is typically a diagnosis code, not a procedure code.